Okay, so it's officially the 1 o'clock hour. So I guess we should probably get started here. I'm going to start by asking if anybody has any questions or concerns that they'd like to kick off class with, whether it be about class execution or about any of the material that we've covered the last few days. I'll just take the quiet black void as a sign that nobody does have questions. And I just want to quickly ask if what? My temperature? I just wanted to reach out and say quickly, Keith, do you have any announcements or anything that you'd like to say?
No, I think we can just go ahead and get started so you could use the time.
Great.
You need.
Awesome. So today we're going to kind of do a combination of essentially kind of two lectures together, two different topics, I guess. I'm going to start by discussing histamine, and we'll go into some of the both central and peripheral, not just nervous system, but kind of body functions of histamine. And then I'll introduce the idea of the cannabinoid system. I think we've got maybe like 4 or 5 slides on that. And then since Keith has been so generous, I'll try to wrap that up in maybe 10, we'll go 8 to 10 slides on Tuesday and kind of finish up talking about kind of the therapeutic applications of the cannabinoids. If you're following along with the different chapters, again, histamine is covered in chapter 13 and Katsung in chapter 16. The roadmap slightly deviated here. Instead of talking about the history of histamine and its discovery, talking about what does histamine essentially do, kind of that overarching effect it has on the body. We'll talk about synthesis and metabolism, synaptic properties, not as much in this particular presentation. We will talk about receptor properties in distribution in the brain as well as in the periphery of the body, physiological properties, some disease states that histamine and antihistamines are used to treat, and then also discuss some therapeutic approaches. So histamine, probably when we think about it, generally plays a huge role in the immediate allergic response. It also has some receptor subtype effects in gastric acid secretions. We'll see that with the H2 subtype. And then it's also a modulator of release in the CNS and peripheral nervous system. Something to kind of note, though, is that modulations in histamine receptor function haven't necessarily been tied to any type of central nervous system disease state, but nonetheless, it still has a role in the central nervous system. Again, what does histamine do and what are its functions? Well, antagonists of H1 are used to treat things like allergies, urticaria. Sorry. Excuse me. Wow, I'm sorry. Nausea, motion sickness, and insomnia. And we'll talk more about these, both H1 and H2 applications. So in terms of the synthesis of and metabolism of histidine, here we see that it's formed by decarboxylation of histidine into the L-histidine decarboxylase. This is actually an inducible enzyme, meaning it's kind of subject to regulation by the cell. We'll again not just be talking about central nervous system effects, but also things like immune cells. So it's interesting to recognize that mast cells and basophils also synthesize histamine, and then stored in these secretory granules. And those secretory granules, it can be stored anywhere from days to weeks within those. And we'll talk about exactly how that release happens for those secretory granules here in the next slide or two. Lastly, it's metabolized by MAOB. So you can see down here, you can also see kind of in this diagram, histamine can be metabolized either by the N-methyltransferase or the diamine oxidase. And again, you have kind of 2 different possibilities in terms of the enzymes that are responsible for the further breakdown and excretion of the metabolites of histidine. So again, in terms of, I did look into too much kind of the preferential distribution of these enzymes and why histamine might be broken down one versus the other. It is possible because we're talking about all the different areas in which histamine is essentially used as a signaling molecule. It's possible that these enzymes are differentially expressed within different cell types, and thus you have pathways that are happening within those different cell types. So when we talk about the ways that histamine is released, classically we've talked a lot about synaptic release and the synaptic functions. Here we can see that there, in terms of the immunological release, is essentially released from mast cells and basophils. So we're talking about those immune cells. It's important to recognize that it's going to mediate that type 1 allergic reaction. That reaction, again, is precipitated by the interaction of an allergen that's picked up by the immune system. So your immune system's kind of overreacting and overreacting to that stimulation. And so often we throw hay fever and acute urticaria under that kind of allergic reaction umbrella. In terms of, and again, we talk about H1 and H2, we'll get to talking about all of the different receptor subtypes and essentially where their mechanism of action is actually altering physiological function. But it's important to recognize that H2 can also be expressed on cells and mediate negative feedback and reduce some of the signaling and release of histamine in the system. While lung cells do not undergo this type of negative feedback system. And it's also interesting to note that histamine can act as a chemoattractant for other inflammatory cells. And so it plays a very important role in the immune response and recruiting additional immune cells. And we'll actually look at kind of the different phases of reaction here in a few slides. Outside of just the immunological release, you can have chemical or mechanical release. So there are certain chemicals that can stimulate the release of histamine. You can see those two listed here. And then secondly, damage to mast cells can also cause the release of these secretory granules as well of histamine into the system. Okay, so again, I've already kind of referred to some receptor subtype differences. And so this particular slide, I think, does a nice job of kind of running through each one of those differences and comparing, contrasting them. So recognize that, I've kind of given my shortened, abbreviated version of each one of these receptor rundowns on the slide itself. And this table also does a really nice job of kind of covering some of the same material. So in terms of the receptor subtypes, H1, I've kind of noted here because there is a differential expression between postsynaptic and presynaptic receptors. H1 and H2 are both postsynaptic, while H3 is presynaptic. And you can see here that the H1 receptors, when we look at how they're distributed in the endothelium, smooth muscle, as well as nerve endings. It's important to recognize here that we're talking about G protein coupled receptors. So the G proteins that they are coupled to are going to be important because they're going to alter the downstream cell signaling cascades. And so again, H1 is coupled to G-alpha Q/11 is going to activate that phospholipase C pathway. It's interesting to note here that the smooth muscles will mobilize calcium upon activation of the H1 receptors and ultimately cause contraction. We'll talk about some of the interactions of the physiological response of H1 receptors when we talk about where they're distributed and some of their physiological properties. H2 receptors, again, are postsynaptic in their expression. As I kind of alluded to, their importance in stimulating gastric acid release. They're expressed, not surprisingly, then on gastric mucosa, on cardiac muscle cells and immune cells, and they're coupled to a different G protein. We see a couple to GS here in activating the adenylate cyclase downstream pathway. In terms of its interaction with smooth muscle, it will link to G-alpha S and enhance the cyclic AMP accumulation and then lead to relaxation. So again, it's important to kind of think about how these G proteins, how they're activated, what they're coupled to, and kind of the downstream physiological response if they are activated. Okay, H3 receptors. So those are presynaptic in nature. They are going to decrease calcium influx through N-type calcium channels. And so we've discussed pretty extensively, the steps to synaptic release. And so hopefully you can predict that if you decrease calcium influx to the presynaptic side of a cell, it's going to lead to decrease in neurotransmitter release. And so this is part of the role of histamine as a neuromodulatory neurotransmitter. It is coupled to G-alpha IO and again inhibits adenylate cyclase. And you can also see that the MAP kinase and also inhibits the sodium hydrogen exchanger. So again, I guess something important to recognize about H3, it's presynaptic in its action, and then also is going to decrease presynaptic release in those instances. Lastly, H4 found in leukocytes and bone marrow during circulating blood, and is essentially going to mobilize stored calcium. And so you can also see the G proteins that are coupled there. So again, it's just always worth, as we're looking at G protein coupled receptors, think about what G proteins are they coupled to, what downstream signaling pathways are being activated, and then what ultimately is going to be the physiological response of the activation of those pathways. And that's ultimately going to very much be tied in with where those receptors are expressed, what tissue types, and what the function of those tissues are as well. So it's important to kind of keep that all in mind as we are looking at any type of G protein coupled receptor. This is a great example of that, just because histamine is not just central nervous system expressed in the central nervous system, but is also expressed on immune cells as well. Okay, so I've been going for a few slides here, and I've realized I'm kind of in that mode of really rattling things off. So I'm just gonna take a deep breath and ask if anybody has any questions, because I know it's nice to kind of always take a moment to catch up. Hi, Keith.
Hi, I'll just jump in briefly here. I'm glad you've been emphasizing the nervous system aspects of histamine receptors, and in my estimation, they're sometimes we kind of forget about histamine as a neurotransmitter, but it is a very important stimulatory neurotransmitter. So it's real good to put some emphasis on that, and also from a historical note. The discovery of the H2 receptors a few decades back was another big monumental event in pharmacology. Up to that time, when we talked about histamine receptors, we were basically referring to what we now call the H1 receptors. But H2 was particularly important because it changed the whole paradigm associated with treatment of gastric ulcer. And up to that point, we pretty much viewed the major regulatory influence over gastric acid secretion as being due to the parasympathetic nervous system, which is involved, but no wonder we weren't really able to significantly treat a gastric ulcer in the cholinergic way, because histamine is a much more important influence over gastric acid secretion compared to acetylcholine. So it was a really big deal to discover the H2 receptors, and the H2 receptor blockers are still to this moment very, very significant as far as treating excess gastric acid secretion. Okay, I'll stop.
Yeah, and it's also interesting to note, as we're talking about it being part of the central nervous system, there is some homology between histamine receptors and some of the other receptors that we'll be talking about. So when we get to start talking about some of the pharmacological targets of both agonists and antagonists, we'll see that there is some overlap and some non-selectivity that occurs. And so because of that, those particular drugs tend to be how sometimes they're referred to as promiscuous. They're hitting a couple different receptor types. And so we'll talk about that a little bit later on as well. So this is a great slide kind of to take everything that we saw on the last slide and create a beautiful pictorial representation of it. So it's showing you again the chemical structure of histamine, the different receptor subtypes that you see down here, exactly what their G protein coupled to, and then essentially telling you whether that G protein is going to either increase or decrease adenylate cyclase activity or phospholipase C, and then essentially give you kind of the downstream signaling cascades that are activated, whether it be some type of immediate response or long-term responses. I like how those are very big descriptions, but we'll talk a little bit more exactly about what that signaling leads to. Again, I think it's sometimes often very tissue specific, depending on what the tissue is, but you can see here that again, these are very common G protein coupled pathways. So hopefully by this point in your kind of academic career, you feel very comfortable looking at G proteins and seeing these different activation pathways. Okay, so I didn't necessarily throw up an entirely separate concept checked question, but what I wanted to just kind of put in here is that I just want to quickly note that all four subtypes are generally constitutively active, meaning that they're generally active and kind of functioning all the time. So what type of drug could act on these receptors to block that constitutive activity? This is kind of harkening back to when we were talking about different types of drug categories in the broadest of sense. And so you've got a constitutively active receptor. So what would happen if you tried to block that activity? What would that drug type be called? And so if you have any questions kind of about this question I'm asking, if it's not specific enough, feel free to pop it up in the chat. But if you have any idea of what the answer might be, also feel free to throw it up in the chat as well. I mean, so yes, so I guess I should be more specific in the question that I'm asking. So what type of drug can decrease the activity that's less than what would normally constitutively be seen? So what drug would cause that decrease in activity that's less than normally is kind of constitutively seen? Okay. I have a few folks that are kind of coming down the right trail here. So again, yay. And this is just, and the reason I asked this is because it's a point of discussion that we've talked about previously. And when I read that these receptors were constitutively active, I just thought it was a great application of a concept that we had talked about. I don't know why I can't annotate. I'm kind of, that's what I'm ultimately trying to figure out here. So I guess where I'm going with this particular question is, when we talk about different kind of classes of drugs, this question kind of stems from asking you about things like agonists, antagonists, and an inverse agonist, which again, we discussed probably 2 or 3 weeks ago. And again, with agonists, they're going to increase the level of activity. Antagonists are going to block, and so you're not going to see either an increase or decrease in activity. And then with an inverse agonist, if a receptor is constitutively active, it's going to decrease that constitutive activity. And so it's kind of the question I'm leading you here with was to hopefully get you to think about, okay, if you're blocking constitutive activity, that would be the action, and it's decreasing that constitutive activity, that would be the action of an inverse agonist. So I just kind of wanted to bring it back to that discussion because I thought this might be a nice application of that. Does anybody have any questions about that before I move on? I just want to make sure that's abundantly clear. So the void of silence I'll take as a good thing. Okay. So when we talk about, we keep talking about how, you know, we've got all these different receptor types, but where they're distributed is ultimately going to alter or affect the way that they function. And so I kind of just wanted, I like the slide because it kind of does a nice job of comparing and contrasting all the different places in which the histamine receptors are distributed. So you have them obviously in the cardiovascular region. So it's also kind of alludes to some of the effects that these receptors have. So vasodilation on areolas and the precapillary sphincters, increased capillary permeability, which is an important point we'll discuss later. And then it also has a heart stimulatory action. We talk about bronchial smooth muscle. The activation caused bronchoconstriction by H1 receptors. What's interesting is that histamine itself is actually used as a diagnostic tool for things like asthma or cystic fibrosis. Those individuals are up to 1,000 times more sensitive, and so it can be important to kind of see if they're raising that accelerated or more intense response. This should only be done under a very tightly controlled, medical situation. The H1 antagonist can also be used to treat asthma, and again, we'll talk a lot about H1 antagonists in the following slides. In terms of secretory tissue, we've already hit upon this multiple times. It's stimulant of gastric secretion and stimulates secretion in both the small and large intestine. In the peripheral nervous system, it has a role in nociception. It's powerful in its receptors that mediate both pain and itching. And so when we talk about things like allergic response, this absolutely makes sense. The H1 receptor, again, is going to be the receptor that mediates this. So when we talk about types of drugs that can mitigate allergic responses, we'll obviously be talking about H1 antagonists pretty extensively. And then also can mediate response to insect and nettle stings. And again, that's part of that heightened immunological response. Lastly, when we talk about the role of histamine in the CNS, there's another slide that kind of alludes to some, I guess, more further expansive functions of it, but it may have a role in appetite and satiety. And we'll talk about how there are some knockout studies that have shown this to be possibly true. And then H3 has a role in presynaptic release of neurotransmitters such as acetylcholine, the amines, and peptide neurotransmitters. So when we talk about the presynaptic expression and how it alters those voltage-gated calcium channels, not surprisingly, it's going to be decreasing the presynaptic release at those other cells. Hi, Keith.
Just the quickest little comment here. I would like to emphasize that there at the bottom of your slide, the potential role in appetite regulation. And, one of the big themes of the course, if you look at overall, is, regulation of metabolism and how that is tied into things like appetite and other factors. And I think this is an active area of investigation with respect to histamine, and might be the sort of thing that will, during the next few decades, become a more important area than it is right now.
Yeah, and we'll talk about some possible drugs that have been kind of started to be investigated for treatment of things like obesity. I saw a question popped up here that I don't think I saw before that I didn't get a chance to answer. So the question is I'm guessing is the inverse agonist like an antimuscarinic or an anti-adrenergic receptor, something that binds to the extracellular domain and prevents GPCR action? Are you referring to the inverse agonist action?
I guess for the inverse agonist, it's more like, I think you kind of answered it when you answered the concept checked, but more about like if it was inhibiting like an anti-adrenergic or an anti-muscarinic, it's completely inhibiting it, whereas like the partial agonist is more like decreasing the activity. Yeah.
Yeah. So kind of like an agonist would be, obviously increasing the activity. A partial would be just increasing the activity to a smaller degree. An antagonist would cause essentially no increase or decrease in the activity of the receptor. And then an inverse agonist essentially is going to block that constitutive activity and lead to a decrease in that constitutive activity that's generally going on, sometimes in the presence or absence of a ligand, just because of the conformational changes of that particular receptor.
Okay.
Does that answer your question?
Yeah, I think when I was looking at the concept check, I was like, well, is it blocking activity or is it just like slowing the activity or the response? But I think that makes sense
now. So when we look at one thing that's kind of mentioned when you talk about histamine is you have to really talk about this triple response, or essentially what it looks like when you have a heightened histamine response within let's say a stretch of skin. And so kind of the test here for this is just kind of a subtle scratch on the surface of the skin. You can see here, there's essentially 3 different parts of the triple response of histamine that occurs here. First, you have a red spot that kind of occurs pretty immediately. This is due to transient local vasodilation. Again, that just occurs within a few seconds. So again, if you just took something and kind of scratched the surface of your skin, that's kind of the first thing you would see. And then up to like essentially a minute later, you'd start to see edema. So you have increased capillary permeability and exudation of fluid from capillaries due to the histamine release. So you start to see kind of that red area that develops around that initial site of injury. And then lastly, you have a flare response, and this is more mediated by the sensory nerve endings kind of increasing that spreading. And so there's an axonal reflex that occurs, and in that spreading kind of diffuses across that region. So again, this is kind of upon that initial kind of irritation of the surface of the skin, you essentially have this triple response of histamine that occurs during that period. So to kind of, again, do a deep dive into the pharmacology perspective of this, again, there are many antagonists for histamine signaling. So there are different ways that you can ultimately alter histamine signaling, or 3 different kind of targets. First, you can essentially counterbalance the histamine signaling by targeting a different receptor type that essentially is altering the same types of pathways that histamine might be activating. And so a physiological antagonist that targets receptors that have the opposite effect, not necessarily targeting the histamine receptor itself. Second, you can treat with inhibitors. And so you can see here kind of the list of the 2 inhibitors that are worth noting, cromolyn and nicotinamide. And then lastly, the receptor antagonist, which I think is probably the most direct kind of counterbalance to histamine signaling. And so what's nice is, again, you can see that chemical structure of histamine, and then just a brief abbreviated list of the H1 receptor agonists, H2 receptor agonists, and H2 and 3 receptor agonists here. And so you can kind of see how some of those overlap with the structure of histamine. Again, these are the agonists that are going to be activating these receptors. And in the next slide, I think we're going to be going through the list of some of the antagonists that are going to decrease this response. So in terms of antihistamines, again, these are going to be the agonists that we're going to decrease response. What's nice about this particular table that's included, I think this is from Goodman and Gilman, you've got it separated into, we'll talk about 1st generation and 2nd generation antihistamines and kind of how those 2 drug classes differ from one another. But what's nice about this is it's a pretty extensive list of both the 1st and 2nd generations, and then ultimately what the usual adult dose is, and then some of the comments that are worth noting, I think, from a therapeutic perspective. I think probably something to note when we're looking at the 1st generation antihistamines, things like sedation. Again, it's going to be one of the major differences that we see between the 1st generation and 2nd generation. And then we haven't really talked about the therapeutic use of the antihistamines in motion sickness, but we will here in subsequent slides. Again, we still see sedation. And then if we look down here at the 2nd generation antihistamines, you'll noticing that they're actually longer in activity than what we saw with the 1st generation. So again, this is just kind of a very abbreviated description of some of the differences between the 1st generation and the 2nd generation of antihistamines. Okay, so this is kind of, I guess, a little bit more in depth when we talk about the difference. Again, the 1st generation, one of the downsides to them is that they have a strong sedative side effect. That's going to be one of the reasons for that is because they have a greater lipophilicity than we see with the 2nd generation, are able to cross the blood-brain barrier. And so once they do, they're obviously interacting with receptors there. Histamine, like I said, has a very similar structural kind of component to it, that it can hit multiple types of receptors, and it's slightly promiscuous. So it's also interacting with things like the muscarinic receptor, the alpha adrenergic receptor, the serotonin receptor, as well as some local anesthetic receptor sites that, as we've seen, this would be things like the voltage-gated sodium channels. The effective duration here is roughly 4 to 6 hours, and it's worth noting that just because the 2nd generation is different in that regard. If we look at the 2nd generation, again, it's less lipid soluble and thus not able to cross the blood-brain barrier as easily. And so because of that, you're not seeing the same sedation effects that we see with the 1st generation antihistamines. Again, if you're looking to treat the peripheral body with something to decrease an allergic response, but you don't want the sedation, prescribing the 2nd generation antihistamine makes far more sense. It's a little longer acting, and it's also metabolized by that CYP3A4. And that's worth noting because in a few slides, we'll talk about some drug interactions that occur with antihistamines and how this particular enzyme is important for preventing some of the negative drug interactions that we see. In terms of just kind of what the 1st generation antihistamines are used to treat, we quickly note here that is used to treat motion sickness. So dioxylamine was approved in 2013. Diphenhydramine. This is the H1 antagonist used to treat acute dystonic reactions to antipsychotics. We'll also talk about some other uses for this particular drug. Non-allergic rhinorrhea. In this case, you're using histamine or the antihistamine to act as muscarinic receptors. Anti-serotonin agent, again, cyproheptadine is going to be the drug that is, again, being slightly promiscuous in that way. And diphenhydramine is used as a local anesthetic. So it's just important to kind of recognize here that some of these drugs that we're talking about don't act solely at the histamine receptor, that there are other kind of targets of that. And in some cases, they're actually causing the therapeutic response that is indicated, not indicated, but is going to the therapeutic response that is desired. So it's used to treat, sorry, somebody threw up here. It's used to treat both motion sickness and morning sickness, both of those different, I guess, clinical or therapeutic uses for these particular drugs. So I guess this slide kind of expands beyond that previous slide. I think that previous slide just kind of threw at the bottom showed, just propped in some clinical uses, and we're going to kind of expand on this slide a little bit more. What I wanted to throw up here though at the top of this slide was really talking about is some of the, we keep talking about some of the effects that it has in the immunological system, but in terms of the brain, the system and the function in the CNS, things like the sleep-wake cycle, circadian feeding rhythms, immunity, learning, memory, drinking, and body temperature. So again, it just recognized that there are a variety of other central nervous system functions of this, but as I kind of alluded to earlier in the lecture, that there's actually no disease state that has been kind of tied to dysregulation of this particular neurotransmitter system. In terms of allergic reactions, things like allergic rhinitis, the H1 antagonist is often used. It's generally this kind of the second line of drugs that are used after the glucocorticoids, and often individuals prefer to use that second generation H1 antagonist because you're not getting those, those sedation side effects that are often undesired. Angioedema precipitated by histamine release. We kind of saw, I guess, a lesser effect of that when we were looking at that triple response. And atopic dermatitis is used to treat with diphenhydramine. Motion sickness is also, again, a use of antihistamines. So for the motion sickness, generally scopolamine is also co-prescribed with the H1 antagonist. And it's also most effective when combined with ephedrine and amphetamines. And so here are the few of the actual drug names for that treatment of motion sickness. And then lastly, for nausea and vomiting in pregnancy, this bendictine, the active component being this dioxylamine H1 antagonist. Back in the 70s, I guess there was some fear of this actually generating birth defects, but I guess there's been no clinical research to kind of substantiate that original claim. Although I think there was some press that was brought up about it because I think there had been some rats that had shown birth defects in the individuals, and it's just some in some of the research that had been done, but it hasn't essentially been validated since that point. So in terms of adverse drug reactions when prescribing things like antihistamines or histamines, the agonist histamine, histamine essentially in terms of adverse reactions is going to cause a dose-dependent response. So depending on how much histamine you're applying, it's going to lead to probably a greater effect. So it can lead to things like flushing, hypotension, tachycardia, headache, gastrointestinal upset. Again, that relationship it has with gastric acid. And it should not be given to people with asthma. I know that earlier I kind of said that it was used as a oh my goodness, it's being used to identify individuals with asthma. And so only under closely monitored testing should that take place. And then also patients with ulcers, disease, or gastrointestinal bleeding, histamine should also not be administered to those individuals. What's interesting to note about kind of drug interactions for the second generation antagonists of H1 is it can lead to lethal ventricular arrhythmias. And so in some of those instances, it's a negative drug combination for so certain antibiotics. And so those antibiotics are actually inhibiting that CYP3A4, which is going to increase the blood concentrations for antihistamines. So again, it's also important to think about the downstream drug interactions, and if you're going to be interrupting any of the metabolism of these drugs, what it's going to do to the blood concentration of those particular drugs. Again, I've been going for kind of a while here, so I'm going to pause and see, does anybody have any questions or concerns?
Just one quick note. I think the histamine category is such a unique one in that rarely is homeostasis lost in terms of there being too little histamine around. It's almost always too much. And so the antagonists dominate this category almost completely because of that unusual feature.
Yeah, but I guess it's kind of the role that it has in the immune system. I think the immune system, so often, more often than not, we're trying to dampen down the overreaction of the immune system versus, stimulating it, because it just tends to be that positive feedback mechanism. Like once that ball gets rolling, how do we kind of mitigate or pull it back so it's not generating the damage that we don't necessarily want, which seems kind of interesting when you think about immunology, which, yeah. Kind of a fun topic. In terms of other antagonists, outside of just the H1s, H2, and I feel like I'm not giving it its proper due here by just including like a single line, but we have hit upon the fact multiple times that it's important for gastric acid secretion. So obviously using it as an antagonist would be reducing gastric acid secretion. So this is one of the more popular forms of treating this particular disease state that's on the market now. H3, as we talked about, is effective in inhibiting presynaptic release, specifically in the neurotransmitter in the central nervous system. And so right now it's currently being investigated for treatment in things like sleep disorders, narcolepsy, obesity, and cognitive and psychiatric disorder. This tiprolisant is interesting because it's an inverse agonist. It's used to treat narcolepsy, and then it's also some other forms of inverse agonists are also being investigated to treat obesity. So again, kind of as Keith alluded to prior, that it's interesting the effects that histamine has in the central nervous system, and I think this is kind of an area of research that's really going to explode in describing exactly how you can use these neuromodulators to finely tune the system and not necessarily mess up kind of the intrinsic main neurotransmitters that are causing the system to function. Next, H4 antagonist. It's a potential in chronic inflammatory conditions, things like asthma, allergic rhinitis, and pain. So much more in the periphery of the body, talking about the interaction it has on immune cells. Okay. So again, that kind of wraps up the discussion on histamine. I want to pause again to see if anybody has any questions or concerns about this section, or if there's any additional comments you'd like to make, Keith. Okay. Well, I guess we'll kind of continue our discussion and go into the endocannabinoids. So following kind of the same structure, what do cannabinoids essentially do? What is some of their chemistry? What are their synaptic properties? What are some of the receptor properties? And then we'll talk about some of the distribution in the brain, as well as the body as a whole. Similar to the histamines, cannabinoids also have expression not just in the central nervous system, but also in immune cells as well. So we'll look a little bit at that. Okay, so cannabinoids. In the 1960s, THC is identified as the active component of marijuana. So this is going to be an exogenous cannabinoid. So the observation made with the activation of these particular receptor types were things like increase appetite, attenuate nausea, decrease intraocular pressure, and relieve chronic pain. At that point in time when in the 60s, when people were using THC, I'd say pretty heavily, they actually didn't know what the receptor target was for this particular drug. It wasn't until the 1980s that the first cannabinoid receptors were actually characterized. So it's very interesting to think there for a long time, you had this, this drug with this unknown target. And it took quite a while for that kind of target to be found. And even beyond that, figuring out what the endogenous signals were that were stimulating that receptor, even I think took further research. So it actually took a long time for the endogenous cannabinoids to be characterized. And we'll look at, and what's interesting about the cannabinoids, the cannabinoid receptors, is that they actually have multiple ligands that we'll talk about here in the following slides. In terms of kind of the role, or what the, I guess, the synaptic effect of cannabinoids is they're going to inhibit presynaptic release of glutamate or GABA. And we'll kind of look at some of the signaling of those G protein coupled receptors and how that essentially happens. And then obviously when we're talking about cannabinoids, it's important to kind of recognize that endogenous cannabinoids, or cannabinoids that are expressed normally in the brain, are your endocannabinoids. And then we'll also talk about cannabinoids that are ingested therapeutically. So the endogenous ligands that you can see here, this obviously is showing you some exogenous ones as well, but anandamide and 2-arachidoglycerol, they're often called anandamide as well as 2-AG. So those are going to be the two endogenous ligands that are most frequently discussed when we talk about endogenous cannabinoid signaling. It's interesting when we're looking at the chemistry of these particular molecules, you can kind of compare and contrast them with THC, and kind of look for some similar structural components that would lead that to be an active agonist for the receptor. In terms of the action of endogenous cannabinoids, it's important to recognize that there is, this is a retrograde signaling mechanism, meaning that you have this neurotransmitter that acts in kind of an opposite way, where it's being released postsynaptically, and it's going to bind to the presynaptic receptor and alter presynaptic release at that receptor. So here you can see, again, the postsynaptic cells kind of a little bit larger in this, because you're looking at the synthesis of these endogenous cannabinoids. And so here you can see essentially the different enzymes that are responsible for generating anandamide in this instance. And so what happens here is you have postsynaptic receptors, whether they be ionotropic or metabotropic, that essentially lead to endocannabinoid synthesis. So this is an area of one of my fields of research. So I can tell you right now that overstimulation of either the M1 or M3 muscarinic receptor can lead to release of cannabinoids, and that excitation of those particular receptors leads to release of either anandamide or 2-AG, and then thus that anandamide transporter transports that outside of the cell, and then it activates that presynaptic CB receptor. Since we're talking, there are both two types of receptor types, CB1 and CB2, and so here you can see the G protein coupling, and again, those G protein effects are going to alter essentially presynaptic release by altering presynaptic calcium. Again, not surprisingly, that this is going to be one of the mechanisms of action to decrease presynaptic release, would be for it to alter presynaptic calcium, or influx into presynaptic calcium. After two different ways or enzymes that break down the cannabinoids are going to be PHAR, or fatty acid hydrolase, and MGL, which is monoacylglycerol lipase. And so these two enzymes are going to be responsible for terminating the signal of the endocannabinoids post-release. In terms of essentially the timing of the synaptic function of these cannabinoids, it can last anywhere from seconds to hours. And so you've got quite a long kind of, I guess, window of activation. Given that they're G protein coupled receptors, it's not surprising that you've got that timing, the timing window. But yeah, I think, again, this is a slightly different synapse that we've seen in the past. So kind of, I guess the big takeaway is to think about them as retrograde signalers, to think about them being released from the postsynaptic cell, diffusing across the synapse in the opposite direction, hitting those presynaptic G protein coupled receptors, and then leading to some type of blockage of calcium influx, thus decreasing neurotransmitter release in that synapse. And so what's interesting to note here is that this synapse isn't necessarily considered a cannabinoid synapse. It could be a glutamate synapse. It could be a cholinergic synapse. And so there's a lot of other, obviously, there's an overlap here with some of the other signaling mechanisms that are taking place in the other neurotransmitter systems that are going to be responsible for this. So yeah. Okay, so in terms of endocannabinoid receptors, like I kind of alluded to, there's two different subtypes of endocannabinoid receptors. There's CB1 and CB2. They're both G protein coupled receptors. We kind of spoke about that previously, how they're coupled to G alpha IO, inhibit adenylate cyclase and voltage gated calcium channels. I guess I can't belabor that point too much. And so in terms of kind of the expression patterns here, you can kind of see in this figure how CB1 is going to be expressed in both the brain and parts of the peripheral nervous system. And then CB2 is going to be expressed in both the CNS as well as on immune cells. And so it's important to recognize the overlap of these two receptor types being expressed in both the brain and then in some instances also the immune cells, because when we think about treating or administering agonists or antagonists to these receptors, thinking about kind of the downstream effects that they might have. Okay, and so in terms of talking about kind of the therapeutic approach and how cannabinoids are essentially used in some of the exogenous ligands that are applied for receptors, it's important to recognize that there is a difference in distribution or a difference in effectiveness between not psychoactive and non-psychoactive, essentially cannabinoids or cannabis. And so we're in our discussion on Tuesday, we're kind of going to discuss further exactly how compounds like cannabidiol differ from things like THC. Again, THC is going to hit through specific receptor subtypes that lead to the psychoactive kind of component of cannabinoid use versus the non-psychoactive use again. And so as you probably notice, you're living in this world, you're recognizing that, you could basically go to a gas station and buy a CBD oil, although THC is still tightly regulated. And again, it's kind of this difference between the psychoactive and non-psychoactive forms of these drugs. And so I guess I'm going to pause here and ask if there's any kind of questions about this introduction to the cannabinoid system.
Just a quick historical note, Katie, you'll probably be talking about this more next week, but THC just absolutely dominated the field forever. And one of the reasons for that really was that cannabis research overall was squelched for decades. So there wasn't near as much done on anything as there could have been. But CBD, cannabidiol, it was only about 15 years or so ago that people even started considering it as being interesting relative to what was already known about THC. So there's tremendous sort of historical artifacts in this field. And as you just talked about, like CBD is one hot commodity right now and has been for the last, just the last few years. But before that, the whole story was THC, but unfortunately that's not the whole story. There's a lot that goes beyond that.
Yeah. And just kind of a quick aside in terms of talking about kind of therapeutic use of cannabinoids. Just kind of a very quick aside to some of the research that I've done. We've obviously alluded to the fact that I was looking at the effects of nerve agents on the brain. And ultimately, one of the findings that I was able to elucidate, I guess, was the fact that cannabinoids can actually stimulate, obviously, presynaptic depression of specific pathways. And so if a individual is exposed to a nerve agent, you obviously have excessive release of, or you don't have excessive release, but you're no longer going to break down acetylcholine in the synapse. And so that leads to excessive stimulation of the M1 and M3 receptor, which ultimately, like I kind of alluded to before, causes release of cannabinoids. So right after exposure to nerve agent, you actually see a slight depression in synaptic activity mediated by cannabinoids. And so that particular lab kind of followed up and started to kind of investigate, is it possible to use some of these cannabinoids to mitigate seizures in nerve agent exposed? And at that point, it was rats. And so in terms of its therapeutic use, I think, again, as Keith kind of just said, I think we're just starting to scratch the surface in terms of the therapeutic use of these particular drug and drug classes. And so I think that's where we're going to kind of start our conversation when we get to Tuesdays. I'm going to be going over some of the therapeutic uses of the cannabinoids, obviously some of the side effects that have been observed with some of those therapeutics, and then just kind of continuing the discussion, hopefully not taking up too much of Keith's time. I'm going to really try to limit it to hopefully like 20 minutes, just kind of wrapping up our discussion on the cannabinoids. But if no one has any other questions or concerns today, I'll just kind of pause for a second because we've ultimately run out of time. Okay. If there are no other questions or concerns, I want to thank everybody for their time. Thanks for a great week. We'll see you on Tuesday. And if you do have any questions or concerns, please feel free to shoot Keith or I an email. Everyone have a great weekend.